There we go. Okay.
Great. Well, welcome everybody. I'm Jeannie Monk, Senior Vice President with the Alaska Hospital and Healthcare Association, and you all know Debbie. I think Debbie knows everybody, and so we're a small group today, which is the whole idea. And so I'd just like to welcome everybody to the first in our series for the AKFlexR Readmission Reduction Collaborative. We're kind of moving in a slightly different direction than we had originally told you at our kickoff in April. We had Tony Eiton there to kick us off with kind of the overall, the high level health equity on a large scale. And now we're going to kind of bring it down and start figuring out what do you do at a hospital level, and what are the things that are in your control, and how can you use that information to help reduce your readmissions and improve outcomes. And we have decided to contract with Cynosure Health, which is an organization familiar to us at AHA. Back when we were ASHNA, we worked with them. Some of you may remember them. It's been quite a while. So they're going to provide webinars to us to all of you over the next 6 months, along with coaching. And we're really excited. And so I know some of you on the call today have already kind of signed on to be part of our collaborative, and others are kind of trying to decide. And we hope that this will give you some information on kind of the big picture about health equity and the kind of work we're gonna do together. And I'll just start by sharing. Yesterday I spent the day in Anchorage along with Pauline and representatives from 5 hospitals, working together in another collaborative, our Wellness and Burnout Collaborative, that's looking at how do we reduce wellness and burnout among healthcare staff. And it was a really great day, and lots of great sharing. And it just really brought home to me kind of how valuable working collaboratively can be, and how trying to struggle. Many of you I know are a one-person show, and you're struggling to deal with a lot of issues on your own in your facility. And so what we hope is that the collaborative can be a way for you to have other people to work with when you're struggling with how do I make progress on some really tough things, and be a source of support, ideas. So I really encourage you to think about the collaborative that way, rather than a burden of one more thing you have to do, of an opportunity to get support and to get new ideas and to make a difference around health equity and readmissions. So with that, I'm going to turn it over to Natalie. And I did ask, I think most people have introduced, if you just want to put your facility in the chat. I think we all know each other. So we won't do introductions today, but we will at future collaborative meetings. So I'll turn it over to Natalie Graves with Cynosure Health.
Wonderful. Thanks so much. Hi, everyone. Thanks so much for having me today. As Jeannie mentioned, my name is Natalie Graves, and I work with Cynosure Health. Cynosure Health is an organization that's committed simply to accelerating improvement in healthcare. So we traditionally have worked in the patient safety space. We've done a lot of work with hospitals all across the country, including hospitals in Alaska, focused on, more traditional patient safety metrics, kind of quality improvement focused in the hospital space. We still do a lot of that work. And one of the things I've been working on over the last year or so in particular is more of a focus on social determinants of health, health equity, and how all of that kind of marries in with patient safety and improving health outcomes as well. My colleague and our president CEO, Bruce Spurlock, can't be here today, but Dr. Spurlock has an amazing wealth of experience and is also a fabulous presenter. So I think you'll see him on future events. And he, he is a physician, so he brings that clinical perspective as well. I have a background in public health, so I have a real interest in figuring out what is the role for hospitals in addressing some of these, social needs, and how can we make sure everyone is on the bus and in the right seats to improve health outcomes for patients, which is what we all want at the end of the day. I didn't mention, I'm our Director of Research and Implementation. Like I said, I work on projects all across the country focused on social determinants of health, health equity. I'm going to talk through a little bit today about what we're doing in different states and more importantly, what we're learning and how we think that can help your work in Alaska. My goals for today are definitely to share what we've learned, what we're working on. I think it will be a bit of a fire hose by design. I'm going to share a lot because I think one of the big challenges is that health equity is really difficult sometimes to get your arms around, and there are a lot of different directions and angles to tackle it from. And so I'm going to share a couple different options. If you have questions or reactions throughout, please put them in the chat or raise your hand or stop me, interrupt me. I'm going to pause at points to get your reactions and feedback, but all of that is really helpful to know what's useful. And my last comment, I'm based in Chicago. So I'm a city dweller, but I have worked with folks all across the country in rural areas. And so I actually think when you're doing this kind of work, one of the most important things is not to make assumptions. And so I will not make any assumptions about rural communities. I think it's good for me to actually not know what I'm talking about because that cedes the floor to you all. So with that, I'm gonna get into it. I attended the National Rural Health Association conference just last week, actually, and someone presented this slide, which I really liked. There's lots of definitions of health equity and social drivers of health and health disparities. And it can sometimes be challenging to understand how they all fit together and what they really mean and what makes sense to focus on. The way this organization, the NORC Walsh Center, framed it was health equity is the goal. And health equity, there are lots of definitions, but I like this simple one that it means everyone has the opportunity to attain their highest level of health. So if health equity is the goal, addressing social drivers of health is the strategy. And because we know that there are differences across population groups between urban and rural environments, there are differences in those social drivers of health. That means we have to address those social drivers if we're going to ultimately achieve equity in health outcomes. And then health disparities are a measure of progress along the way. So disparities in healthcare outcomes are a way for us to understand if we're making progress and what we need to focus on. So I just wanted to share that as kind of my framework for going into this conversation to give you a sense of how I'm thinking about these things. So you all probably know this really well. There's been a lot of conversation about social drivers of health. This is, I think, one of the sources of truth documents that talks a little bit about the different social drivers of health and what they are and what they mean. So I think, the biggest takeaway here is healthcare services only influence actually a very small portion of ultimate health outcomes, right? Of course, we need services when we need them, when we're sick or injured. But if we want to really overall and over time change health outcomes for our patients and communities, then we need to think beyond and look beyond investments only in healthcare. Some of these things are fixed, you're born with the genes you're born with. A lot of the others are modifiable. So a lot of this, which makes a lot of intuitive sense, is based on individual behaviors. So those are things like whether or not you smoke, exercise, eating habits, getting enough sleep, all of those things which are individual behaviors. And if you start to peel back the onion there, you'll realize that those individual behaviors, though, are also not only based on willpower alone, right? A lot of our individual behaviors and the choices we make are shaped based on the choices we have. So perhaps I don't get enough sleep, and that I don't get enough sleep because I'm living in a household with multiple generations or multiple families because there's not enough housing in the area, or I have an extremely stressful job because I work in an industry that's very dangerous. So that contributes to my stress levels and my inability to sleep. So even though you might say that's an individual behavior, there's a lot to peel back there in terms of thinking about how we can build communities and support structures that help people make those healthy behaviors. And then the orange bucket is kind of the classic, social structures that we think about. So things like availability of transportation, transportation to both get to medical appointments and to get around in the community generally, availability of housing, things like viruses too. If there's a lot of viruses, circulating in your community, we're familiar with that. That obviously has an impact on health. So why should we as a hospital or healthcare organization think about these social drivers of health? This is a slide that kind of illustrates the connection between the health outcomes, which our organizations really focus on, and the theory of how intervening earlier can address some of these things. So over on the right-hand side are your things like health outcomes, things like readmissions. And as you kind of, again, dig deeper and deeper at what's causing those different items, you start to think about things like, well, perhaps we have a lot of diabetes in our community, a lot of patients with diabetes. So that's leading to worse health outcomes overall. And this is the kind of data that we start to see in community health needs assessments, right? We start to understand what the burden of disease is in a community and how we might think about providing services or preventive services differently to do that. But if we keep backing up, we might start to see things like, well, what's causing higher levels of obesity or diabetes? Perhaps it's that there are high levels of obesity in the community. And if we start peeling that back again, maybe one of the reasons for that is because people lack access to healthy foods. So if your only grocery store in your community looks like the inside of this convenience store, you're not going to have access to the kinds of foods you need to support a diet that will help you prevent or manage diabetes. So the whole idea here is, how do we think about getting to this lowest level where we can intervene and hopefully improve those outcomes down the road? And of course, if we can do that, then hopefully we can have some kind of impact on those health outcomes at the hospital level, things like readmissions. I'm going to pause for just a minute. So what I'm going to talk about today is work we're doing across the country in 3 different areas to think about how hospitals might advance health equity and address social determinants of health. The first is through area level analyses. So we've done some work in California and in Montana, looking at how hospitals can understand the different needs in their community and how they might intervene accordingly. The second piece is about how hospitals are screening for individual needs. So this is both screening for individual social drivers of health or health-related social needs, things like homelessness or transportation needs or difficulty paying utilities or food insecurity. And also here, I'm going to talk a little bit about work that we've done with hospitals around collecting basic demographic information. Because the third bucket I'll touch on is about identifying disparities in quality measures. So this is things like stratifying your readmissions data to identify disparities. And of course, if you're going to stratify something successfully in a way that gives you meaningful information, the inputs have to be accurate. So your data on race and ethnicity, or payer, or gender identity, or sexual orientation, any of those items needs to be accurate. And there's a lot to think about in terms of how to collect that demographic information. All right, so starting with these area level analyses, as I mentioned, there's a lot of existing data sources and actual indices that already exist to characterize these kinds of the level or availability of these different social drivers of health in various communities. So one example is the Centers for Disease Control's Social Vulnerability Index. This index was actually developed to help communities, to help understand which communities were most vulnerable in the event of some kind of emergency. But nonetheless, it gives us an interesting snapshot of the level of vulnerability or need by zip code across the country. So you look at these kinds of maps and you can see typically the darker colored areas have greater need and the lighter colored areas have lower need. And so it becomes interesting to see that, of course, again, something we all kind of know intuitively, levels of need varies by geography. So the SVI has 4 categories, measures of socioeconomic status, household composition and disability, minority status and language, and housing and transportation. So really maps with all of those different social drivers of health. In California, they also developed their own index of social needs called the California Healthy Places Index. And they actually have used this index to, respond to the COVID-19 emergency. Actually, they used it to help prioritize how to distribute vaccines. They, look to the highest areas of need and use that to help prioritize decision-making. So this is a similar idea as the CDC's SVI, different domains to capture those different social drivers of health and different metrics within those domains. So what we did is we worked with hospitals and said, well, it's all well and good to have this information at a zip code level, but what a hospital wants to understand is, well, where are my patients coming from? Where do my patients live so that I can support the needs in their communities and really make a difference for the patients that I'm serving or that I'm accountable for in some way. And so what we did in California is we merged this Healthy Places Index data, so the data on kind of the social drivers in a given zip code, we merged that with hospital service areas. So we first created these hospital service areas for each hospital based on discharge data. So we looked at discharge data and Medicare fee-for-service files and said, for hospital A, your patients come from these 12 zip codes, and 50% of them come from zip code A, 10% come from zip code B, on and on. And then we overlaid the zip code level socioeconomic data with the hospital service areas to create a hospital level index score. So what this does is it helps a hospital understand, it helps the hospital weight their score based on where their patients are coming from. So if a hospital sits in, let's say, a community that has a relatively low level of need, but a very high percentage of their patients come from a neighborhood or a zip code right next door that has extremely high levels of need, which can happen in a place like California, in some of these really urban areas, then we want to make sure the hospital score actually reflects the needs of the patients, not just where the hospital is physically located. So then what we did with these overlaid scores is we created a map to be able to drill down both at the domain level. So being able to look across those different metrics like economic metrics, transportation, social, pollution, all those different areas, and also be able to drill down at the zip code level. So this map here shows the this hospital service area. So each of these colored shapes are different zip codes where the hospital treats patients. And then each of the colors represents the different scores, HPI scores for those zip codes. So the darker scores are higher levels of need. The lighter scores are lower levels of need. So you can see, looking at this hospital set of scores, if they're interested in really investing in some kind of underlying social drivers of health to advance health equity in their population overall, they're probably going to want to focus in these neighborhoods or areas where the colors are darker. So this tells you kind of where the greatest level of need is. And then over here on the left tells you what the greatest level of need is. So again, broken out by domain, you can see here that they have this community that's highlighted in this screenshot has greatest level of need in the economic and social domains. By contrast, they have really great scores on the pollution side. So I think, just as a case example, a hospital might say, well, maybe we would like to focus on something related to air quality. But if they look at this data, they would say, actually, air quality pollution is not at all a driver. If we really want to make changes, we need to focus on economic issues and specifically in these neighborhoods. So it helps to really focus down for the hospital specific patients and in specific communities, what the needs are and where to focus. Now, the other thing we did, as we said, well, how can we understand the relationship between investing in these social drivers of health, which for a healthcare organization can feel at times out of scope in a way, right? It can feel really far away from your kind of day-to-day mission of providing patient care, the kind of quality metrics that you typically focus on. And so we wanted to explore, is there a relationship between the conditions of these different neighborhoods, the social conditions of the neighborhoods, and the quality metrics that hospitals are typically reporting on and looking at. So we looked to see if there's any correlation between HPI score, or the socioeconomic scores for each zip code or each hospital, and then their quality scores across a number of different quality metrics. And we found that in some instances, there is pretty strong correlation. So the highest correlation was actually between breastfeeding rates. So hospitals with higher levels of need, so lower HPI scores, higher levels of need, typically had lower scores of breastfeeding. Similarly, there was some correlation between some different HCAHPS measures that are highlighted here on the screen. So what this tells us is, if a hospital wants to improve on those metrics, one strategy can be to try to improve the overall conditions of the neighborhoods that those patients live in. There is a relationship between overall community level conditions and scores and those hospital outcomes. In other words, the hospital can't do it alone. So it's important to partner externally. Now, there are other measures that weren't well correlated, where it seemed not to matter what the overall neighborhood conditions were. And these make a lot of intuitive sense too, I think. So things like surgical site infections, unplanned wound reopening, these are things that are really within the control of the hospital, right? You can focus internally to make sure you have processes and systems and resources in place to perform well on these metrics, regardless of what the external conditions where your patients live look like. So in some instances, in some quality metrics, it makes more sense to focus internally, and on others that really extend beyond the walls of the hospital, of course, there's an opportunity and a need to partner externally to improve on those metrics. So Jeannie mentioned something about this, or something that made me think of this at the beginning. We also recognize that, of course, disparities exist before patients come into the hospital, right? Those underlying social conditions, social drivers of health vary for patient populations before they even show up through our doors. Sometimes there are disparities that are exacerbated or that show up during hospitalization. And then there are also disparities that exist or persist after hospitalization. And so our role as healthcare organizations is to figure out, where can we best intervene? What can we control? And where can we partner? Where do we need to focus on our own processes within our own walls to mitigate and prevent those disparities from worsening or existing in the first place? And then where can we go outside our walls to partner with organizations to address some of those disparities and lessen them before patients show up in our organization, and also to help mitigate them after patients leave? One more thing we found when we looked at the data in the California HPI was that even in the lowest resourced areas, or the areas where the greatest need, so the areas with the highest HPI score, there was still a lot of variation in performance on those quality metrics. So correlation is not causation, right? We all know that. And so just because an organization served patients in an area with a high HPI score, it didn't necessarily destine them to have low scores on something like breastfeeding measures. In fact, we saw a lot of variation in quality scores across a given quartile of HPI. So what we did here is we broke hospitals up by HPI score into 4 quartiles. This first quartile here is the lowest, or the hospitals with the lowest HPI score, so the greatest need. And then these gray boxes here are the scores, the breastfeeding rates. And so you can see there's a lot of variation. And up here in the red, these are really high scores in areas that have a lot of need. And so these are bright spots. These are areas where we want to learn what those hospitals are doing, so that we could spread that information. These are the ones who are really helping to close those gaps and address those equity needs in their communities. So we did this work in California. I mentioned California. I'm from California. It's a very interesting place. A lot of urban environments, also a lot of rural environments, but it's kind of its own beast. And we also worked with the Montana Hospital Association, and they saw this and they were really interested in how they might apply this to their communities, which are very different. And they had questions about how can we develop some kind of similar product or similar tool that takes into account the unique needs of our rural communities. So some of those questions were about small numbers. How do we accurately capture the needs of rural communities when sometimes those data and information is essentially just washed out in statistical analyses? How can we also include domains that are most relevant to our patients? So we've worked with the Montana Hospital Association over the last year or so to create a similar version of this area level analysis called the Montana Index for Healthy Communities. And we did the same thing as we did in California. So we took Montana specific hospital encounter data to create those hospital service areas. And then we overlaid geographic data sources or those data elements that help us understand the levels of socioeconomic need. And then we combine those two to create scores for each Montana hospital. What we also did with the Montana team is we created essentially a new index that included different domains. So some states use the CDC's SBI as a data source. California had created its own HPI with specific domains and measures. And in Montana, we went through a process with their with partners across their state to develop our own set of domains that made most sense, again, based on the needs of their communities. So a couple things to call out here. A lot of these are really similar as what we see in other kind of standard indices. One of the things that we added that was really important to the group was internet connectivity. So this probably resonates. There's a lot of communities in Montana that don't have good internet connectivity. And of course, that has a lot of implications for access to healthcare, but also access to any number of other things, employment, kind of general connection with others and the like. And then we also included a measure that we called historically marginalized. So it was important to the group to highlight these different populations who have been historically or currently marginalized in some way, or who have historically or currently have higher risk levels for any number of reasons, and wanted to reflect that in hospital scores so that they could understand how to recognize and address those patients' needs. So this includes things like the percentage of American Indian and Alaska Native patients, the percent who are Hispanic, percent who are non-white, folks living with a disability, patients who are over age 80, and who are veterans. The other thing we did in the Montana Index was create not only the socioeconomic context, but the health context as well. So even though on that first slide, we saw that healthcare is only 10% of the contributor towards overall health and well-being, we know that in rural communities, it can be a huge driver if you don't have access to healthcare at all or access to services at all. That's a huge challenge. And so, and there's an interplay between socioeconomic drivers and those health drivers. And so it was important to the team in Montana, and I think makes a lot of sense to also include side by side these kind of this health context or these domains that reflect healthcare the status of healthcare as well. So we also included these as part of the measures, things like disease prevention, health insurance status, and measures of provider supply. So pretty similar to the California example, again, what we get out of this is a set of scores across different domains. And so we can see there's variation across these different domains, which tells us there's different levels of need and helps us figure out where to prioritize in a given community. So here on this example, we have an overall score for the hospital. That's the overall HPI score. Then we also have a health score. So that's the sum of all of these different health domains, and a socioeconomic score, which is the sum of the socioeconomic domains. And you can see here right away, there's a really big difference between the health score and the socioeconomic score. So in this index, higher indicates higher levels of need. So you can see here, the health score of 27 is quite good. They actually are doing quite well on a lot of these measures of provider supply and healthy behaviors and disease prevention and the like. But their socioeconomic score for their community is quite a bit higher. And so what that suggests is if the hospital is interested in improving health outcomes, perhaps they have greater opportunity and can get a better return on investment if they focus on some of these underlying drivers where there's greater opportunity to affect change. So again, just another example of how to use these maps and think about these maps to focus both on where to intervene and what to intervene on. This is an example of a community in Montana. And one of the things they saw was that there are these communities out here where there's a relatively low number of discharges from each of those communities. But all of these communities in this geographic area also had relatively higher scores. And so what that told the team is, well, hey, maybe our strategy needs to be focusing in on this geographic area. We can also look at this index data by domain and by zip code. So similar to the California version, except this is in a table and not a map. You can drill down at a zip code level and a domain level, and again, start to see patterns on where the greatest need is, and therefore what might be the best place to intervene. So we developed this tool, and then I went out to a couple pilot sites in Montana a couple weeks ago and had conversations with them to present this tool and have a conversation about how they might use it to prioritize efforts in their community. And I wanted to just highlight a couple things that I learned, because I think this is, we can talk until we're blue in the face about data and we're swimming in data. But the most important thing to us and what we want to help do is actually translate that data into some kind of action and improvement. And so a couple of things that stuck with me from our conversations. First, the teams felt like this data from a hospital perspective, translating these socioeconomic needs down to a hospital level and really focusing on your specific patient population. It was a different way of looking at the data and kind of filled a gap and helped them connect, I think, a little bit differently and say, yeah, these are our patients. This is something we can work on. I heard over and over again, perhaps not surprisingly, about the partnerships and resources and good neighbors in all of these communities. And these are small communities, but it really just stuck with me how we had an icebreaker activity about what do you love most about your community. It was always focused on we have a lot, or even if we don't have a lot, we have something to start with and work on. And we certainly have a lot of commitment to helping. The other thing that surfaced in all of these conversations is that there's always a group of others, right? And I think, again, we kind of know this, but there's always, no matter what community you live in, there's a group who has been left out historically, who has been left out currently for any number of reasons, intentional or unintentional. And looking at data in this way can challenge some of our own biases and knowledge about who is left out and how can we then bring them in. So in Montana, it was the folks on the other side of the mountain. In Chicago, it's the north side versus the south side. Again, I think we all kind of have this awareness that there are people out there who we could do a better job reaching and supporting. And that's what this equity work is all about. So it helps us think differently about who those groups are and how we can reach them. We heard a lot about how health and social needs are intertwined. Again, we can't separate them. I think that really is shown in readmissions work, which I'll talk a little bit about in a minute. And then again, this was true in Montana. I'm sure this is true with everyone on the call and in your organizations. You are teams of committed, thoughtful, and energetic folks and ready to do the work. So how can we give you the tools you need to do that? So I'm going to skip that slide. I'm going to pause. That was a lot about area level analyses. Any reactions, questions before I move into the next section about individual level screening for social drivers of health? Okay. All right. So the other thing we've been doing with organizations, and this might feel a little bit more tangible, is we've been having conversations about screening individual patients for social drivers of health. So some of you might know this, but I don't think any of you actually are PPS hospitals, so you might not. So last year's CMS, last year's final rule introduced a new measure for PPS hospitals who will now be required to screen all inpatients over the age of 18 or older for 5 different social drivers of health or health-related social needs. They'll have to ask patients about food insecurity, housing instability, transportation needs, utility difficulties, and interpersonal safety or domestic violence. And so, as you might imagine, there is a lot that has to go into standing up processes to systematically collect this kind of information from patients, and also then to actually do something about that when you get those screening results. If someone says, yes, I do have housing needs or food insecurity, how can the hospital connect that patient to resources or help bring new resources into the community? So we've been having conversations, webinars with hospitals all across the country who are wrestling with this question and starting to stand up processes to do these screenings. And so I thought I'd share a couple of things that we're learning. First, this is new and it's complex. So a lot of this work has started in the outpatient setting. Some primary care providers, I've heard a lot from different federally qualified health centers or rural health clinics or others who have received grant funds to do this kind of work. But a lot of it has been so far, and a lot of the evidence base is from the outpatient setting. So this really is kind of a brave new world for hospitals. It's also complex. So I think, there can be a perspective that, of course, we should do this. It's really good for our patients. It's really easy to just ask these questions and add it into your workflow. But we know that is not the case. So it's staff time to be able to ask these questions. It's training and support to be able to ask them in a way that engenders trust. There's a lot of work to be done about understanding what to do when patients do express that they have needs, connecting with different community resources and referring and following up. There's a lot to think about in terms of documenting the data in a way that you can then analyze to inform improvement efforts, or add different Z codes so that you can recognize those different efforts. So it's complex. I probably don't need to harp on that anymore. You know that. The other thing we've learned is that the most efficient and the most effective way, but really the most efficient way to do this work is to engage your community members and patients along the way. So patients know where the resources are in the community. Family members of those patients know what resources exist, what's helpful, can help you build different resource lists. Patients, whether they're on a patient family advisory council or kind of just generally available or interested in providing feedback, have really good perspective and ideas about how to design these screening processes in a way that build that trust and that really lead to better outcomes. The other thing we've learned and seen is that a lot of the organizations that are having success and that are then growing those programs are starting small. So it can be overwhelming to think about, screening all inpatients from day one. A lot of organizations start with a specific patient population. So maybe maternity patients or Medicaid patients or patients that are coming to a certain clinic. Again, a lot of people are starting in the outpatient setting and then porting that over. It can be easier to start small, test out those screening, documentation, and referral processes, and then think about ways to spread that across the organization. Identifying and then aligning with other resources is really important. So again, this work is happening in pockets in a lot of different areas. And I heard a lot about this when I was at the conference last week as well. There are a lot of pilot programs, grant-funded programs, different payer programs that are incentivizing similar things. And so it's, I think, really important at the outset of any initiative to take stock of what already exists. Is there someone in your organization or in your community who's already doing this work? And how can you learn from them so that you can go faster when you get started? And then the other piece we hear a lot from hospitals is, how can I ask these questions if I don't have an answer or a solution or a way to help? And hospitals are, understandably hesitant to ask about these things if there aren't resources readily available. And so we've had this conversation, gotten perspectives from a lot of different folks. One that stuck with me is from a patient who said, I understand that the hospital can't meet all my needs, but if they ask these questions and express empathy and understanding and kind of work with me to figure out what a next step could be, that means a lot. They don't have to solve all the challenges, but asking the question means a lot. And by asking the question, you then start to better understand what the needs are and what you might do with it as an organization and as a community over the long term. And then the final piece, kind of similar to what I just said, is that patients want to know why you're asking these questions, and your staff want to know why you're asking these questions too. So this is new. It can feel, I think, a lot of people have reflected, it can feel intrusive, it can feel unexpected and awkward. These are not questions we're necessarily used to asking or hearing in a healthcare setting. And so one of the, I think, easiest things to apply as you're starting to think about any kind of screening process is it's important to let patients know why you're asking and how you'll use the information. And that can go a long way in kind of creating ease and trust in the process. So we're also learning that hospitals face a lot of the same challenges: large, small, urban, rural, highly resourced, lesser resourced. A lot of these challenges are similar across all sorts of different organizations. Staff availability and systems to collect this data is a challenge. There aren't magical fairies that can come around and ask these screening questions and solve all of the problems. So we've heard from a lot of different models at different organizations. Some are using care managers, others are having their registration team ask these questions. Some are having their nurses ask. And this is the kind of thing that we think we can help your organizations think through, brainstorm, and problem solve around to test out different approaches. So having the right people ask the questions is important. The right training, as I said, this can be challenging, awkward, new for the people asking the questions and the patients hearing and answering the questions. And then we could probably have multiple hours worth of sessions on the right tools. So I know there are some EHRs who have built-in screening tools for these kinds of questions. Others are working on it. And in many instances, we just have a long way to go and probably need to think about what we can do in the interim to use tools. I'm really sorry. Let me take my cat out of the room. The second big challenge that a lot of hospitals face, particularly in small and rural communities, is the availability of resources and capacity to support patients who are referred. So in some communities, the resources simply don't exist, and others, the organizations might exist, but they just don't have the capacity to meet all the need. And so, this is a real challenge. I think one of the opportunities in collecting this social needs data from patients is that we'll start to get a better understanding of what needs exist and then can use that information to advocate for additional resources, additional services, to bring new providers into our communities. And then the final piece is that actually doing something with these data beyond using it, to address patient needs in a one-on-one situation, looking holistically at the data to determine patterns and disparities and overlaying it with kind of quality metrics and things like that is complex. And there's a whole science behind determining what is a disparity, how do you calculate disparities, what's statistically significant, and all of that. And that is complex as well. So most hospitals that we've spoken with really are in the planning phases. This is a small sample size from a webinar we held, but I think it speaks to what we've heard overall in conversations, that a lot of people are in the beginning stages of this. And another thing I wanted to mention today is kind of an important takeaway is, I think one of the most important things you can do in starting this work is figure out why you're doing it, right? What's motivating you? Because that's going to be really important in building the will in your organization for all of the different people and partners that you have to have involved in building these processes. And understanding why you're doing something is also going to shape your strategy. So if you're doing this only to meet CMS requirements, for example, you'll probably design your process a little bit differently than if you're doing it because you have to meet CMS requirements and Joint Commission and some payer and some other grant program, right? You have to understand what the inputs are. And if your kind of why statement is not tied to any specific mandate or regulation, but rather is about how can we do what's best to meet our patients' needs, and maybe how can we do what's best to meet the needs of our patients who are experiencing homelessness, for instance, that will also shape the way you think about your program and think about how you prioritize. So I think it's just important to spend some time thinking about why are you doing this, and step back from what can be an overwhelming amount of requirements and needs and standards, and really think about how can this improve the lives of patients. A couple questions here. A couple of thoughts here. This might be more helpful when we send the deck around as kind of tips to get started. So actions, set that vision of what is most important. We've also heard this isn't work that fits really neatly in one team's wheelhouse, right? You have to engage a lot of different stakeholders across your organization to do this work well. So you'll probably need nursing and the quality team, case managers. IT is huge to get these systems figured out so that you can not only collect this information, but also analyze it and use it in a way that can inform change and investments over time. I mentioned this a little bit already, but your patients and community members and talking with those folks to get perspective is not only, I think, kind of the right thing to do in terms of designing a program that will really meet the needs of patients, but it's also, as our partners at PFCC Partners, which is a patient engagement organization, patient partnership organization, say, it's the most efficient way, because the patients will tell you, this is what we need, this is what works, this is how we can collaborate together. So a plug to start with data and then validate that data with your patients, your team, your community members. That will help you go farther, faster in meeting these goals. I'm going to skip over these for our next conversation because we're almost to the end. Actually, let me go back here. So a couple of again considerations if you're thinking about standing up a program to ask patients about social drivers of health, or to just ask patients about demographic information as well, collecting information about race and ethnicity, sexual orientation and such. Those can be challenging conversations as well. And so a lot of these considerations apply in those instances too. So do your staff and your providers have a common understanding of why you're screening patients and how you'll use the information? This is the why statement. What's your vision for why you're doing this and how it will help your organization and your patients and your community in the long term? Similarly, how will you explain to patients why you're asking about this? Do the staff, are your staff who are charged with this new task supported and trained? What are your plans if a patient does screen positive? And then starting to think about how you'll use this data over time are just some of kind of the early questions we would ask when standing up a process like this. And then the question is, well, what is the role of the hospital in addressing these social drivers of health, right? If you have a large population of patients who are experiencing homeless, what is the role of the hospital in addressing that? And this looks really different I'm so sorry. This looks different depending on the community that you're in, right? In some larger organizations, we see this concept of an anchor institution. And so some hospitals are investing in housing for their staff or for patients, particularly in things like transitional housing. That might not be an option, particularly in, rural communities, or if you're, don't have a lot of extra funds to invest in things like providing housing. It also might not necessarily be aligned with your mission of providing care. But you may be able to do other things. In fact, you may be able to do other things to partner with and advocate for changes that can address things like homelessness. And so I think there's a lot of opportunity in gathering this data, not only to address those needs or refer folks to others to help address those needs on an individual basis, but also to think about, what does this tell us about the investments we need to make in the future that we can advocate for and help share that data out that can lead to change. Hospitals are great conveners. They're often, largest employers in communities, very highly respected, have a lot of resources and knowledge and understanding of community needs. And so hospitals often are really successful as conveners to pull together different organizations. And then one of the other things we also like to suggest is that sometimes it can be easiest to start at home in your own organization. So you probably have folks who work in your organizations who have a lot of these social needs. And so perhaps in the theme of starting small, there's an opportunity to think about what you can be able to do to support the needs of your staff. Again, another example of, there's a lot of evidence or a lot of research and examples of how hospitals are playing different roles in addressing social determinants of health, everything from changing hiring practices and having a more targeted strategy to work with different supply chain vendors and the like, providing grants to improve availability of social services, advancing systems change, these high-level, lofty goals. The other thing we can do is just to start to systematically ask these questions and think about how they can influence one patient's discharge plan, one patient at a time. So if you screen a patient and they say, yeah, I don't have enough food at home, how can you impact that patient's care? Probably help them avoid getting readmitted. And now you begin to have this understanding of, well, how prevalent is that in my community that not enough people have food? So we can think really high level about these lofty goals, and we can also just start one patient at a time, focusing on something like readmissions. In the next session together, our plan is to really dig into what I just shared around setting up processes to screen for those social drivers of health questions. We have a lot of resources and tips and things to share. And our goal is to help you start to think through some of those questions of how could you set up a process. All right, I have 5 minutes left. I have just, I think, 2 more slides. The last bucket that I haven't touched on as explicitly yet, and an example that comes up a lot when thinking about equity and disparities, is the idea of stratifying quality metrics by different demographic categories. So I think a classic example is could you stratify your readmissions data by race to show some kind of disparity? This is made up data that we put together as part of some work we're doing in California, again, where hospitals will be required soon to stratify a number of different quality metrics over a number of different demographic categories. And again, I think the biggest thing we've learned here is it's complicated. And it's especially complicated if you have small numbers. And there's a lot that goes into how do you do the basic statistical analyses to look at any measure across some different demographic group. And then how do you interpret and use that information to drive investments or partnerships or programs? And so that's another, I think that's going to be another part of this series together is how can you look at your readmissions data and stratify it by some variable of interest and use that to drive change in your organizations. So here's what's next. In subsequent sessions, I will not be talking nearly as much. The goal will be that we'll have a more discrete topic to focus on, and then we'll spend a lot of time getting input from you, hearing your questions, doing a lot of workshopping around how can you actually come up with a plan to implement something in your facility. We'll have some time between sessions for you to go out and test that approach, and then come back and have these, what we're calling deep dives, to hear what you tested, what worked well, what didn't work well, go out and test it again. So it'll be really hands-on, focused on taking action and learning along the way together. That's all I got. Questions now or later, I would love to hear them. If there are things that resonated or didn't, would love to hear that too. And we'll definitely work with Debbie and Jeannie as we prep the content for the next session, and really look forward to meeting you all and working with you.
Thanks so much, Natalie. That was great. Any questions from anyone? Let's stop sharing.
Well,
Maybe,
Natalie, thanks for sharing today. I know that the facilities are really diverse, and the thing that you said that resonated the most with me is one patient at a time. And I think for those of you in very small facilities, I think that's how you function, is one patient at a time. There are some people from larger facilities who maybe maybe think a little broader, but I think for a lot of you, all you can do is look at one patient at a time. I really appreciate that.
Yeah,
Any
I do too.
questions or
And
comments from anyone? I think that's just background noise.
I wanted to mention, sorry, that's coming from here, but I'll talk loud. I just wanted to thank everyone for coming, especially those of you that didn't participate last year in our readmissions collaborative. I think this is so exciting to start this work this year. And we had 6 hospitals that had joined, and today we have 4 new ones coming on listening today. And so just let me know if you want to participate and be on the invites for the future calls with Cynosure Health, working with us. And we will, in the next few days, we'll find a date in June to have the next meeting that Natalie mentioned, what we're going to focus on, and everyone will be participating a lot more in that next call. So you will be getting an invite in the next few days once we work out a time with Natalie and Cynosure. So anyone else have any other questions before we give you back your morning? At least you still have the full day today. So I know it was early Alaska time, but this was what worked for everyone. So
Debbie, this is Kate. I just wanted to share.
Hi, Kate.
Hey, I just wanted to share really quickly. I put a link to the Alaska Health Equity Index map in the chat for people to kind of take an initial look at. It's not as detailed as what Natalie can offer, but just kind of a preliminary look at the data.
Great, thanks, Kate. Yeah, and I should have mentioned, Natalie, I don't know if you met before, but Kate and Erin are on the Flex team. They're both were on today. So glad they could be on and be part of it. So looks like it's 9 o'clock. So thanks everyone for joining today and taking the time to listen in, and let me know if you're interested in continuing to participate with our collaborative. And so we'll see you all in a few weeks once we get that date planned.
Thanks, everyone.
Thanks. Bye-bye.
Bye.
Thank you so much.
Thank you.
Thanks.